Hello everybody and welcome to our module on gastrointestinal hormones. Let's begin our discussion by talking about the gastrointestinal hormone gastrin. Gastrin is the major hormone that stimulates acid secretion in the stomach. It's produced by cells called G cells. That's easy to remember because they produce gastrin, and these cells are found in the mucosa of the antrum of the stomach. I'll show you a picture of that in a minute. Interestingly, even though this hormone is secreted by the stomach and acts on the stomach, it actually travels through the blood to get to its site of action. It's secreted into the portal vein blood, and then it has physiologic action on the parietal cells in the stomach. There are two gastrin hormones. One's called little gastrin, one's called big gastrin. I've shown the structures on the screen here. You can see that they are very large molecules that travel through the bloodstream to exert their effect. This picture on the screen here shows the mucosa of the stomach. This is the muscular layer of the mucosa. The epithelial layer is on top, and everything in the middle is the lamina propria. And within the lamina propria, there are these ducts lined by cells, and those are the glands of the stomach which secrete gastric juice. And you can find the G cells in the glands of the mucosal layer in the antrum portion of the stomach. That's the portion of the stomach closest to the pylorus and the duodenum. From those G cells, gastrin is secreted, and it travels to the parietal cells, which are found mostly in the body of the stomach. They're also found in the glands in the lamina propria of the mucosa of the stomach, and that's where gastrin exerts its effects. Gastrin has three important effects, the most important of which is to stimulate acid secretion by the parietal cells, and we'll talk about that in detail in a minute. In addition, gastric can stimulate the growth of the gastric mucosa, and we know this because patients have been studied who have gastrin-secreting tumors, which are relatively rare, but they have a number of effects that we'll talk about later, and one of these effects is to cause hypertrophy and hyperplasia of the stomach. And then finally, gastrin has been shown to increase gastric motility, and this is easy to remember if you just think of gastrin as a hormone that gets the stomach ready for digestion, starts pumping acid so that the pH will be low to start to digest proteins, and it increases motility so that food can begin to move through the stomach. Let's talk about the mechanism of gastrin's effect on acid secretion. Gastrin can directly stimulate a parietal cell to secrete acid. However, the more important way by which it stimulates acid secretion is indirect. Gastrin can affect cells that are close to the parietal cells called enterochromaffin-like or ECL cells, and these cells mediate the gastrin effect. When they are stimulated by gastrin, they will release histamine, and then histamine can activate the parietal cells. And it turns out this is the most important way by which acid secretion is stimulated. And as you may know, there are drugs that are antihistamines, and they block this mechanism of gastrin-induced acid secretion, and therefore they lower the acid level in the stomach. As I told you before, however, gastrin can also directly stimulate the parietal cells, although this mechanism is less important than histamine. And then finally, parietal cells can also be stimulated by acetylcholine via the vagus nerve. So what are the stimuli for gastrin secretion? Well, like I told you before, you can think of this hormone as the hormone that gets digestion going. So when the stomach is distended after you've consumed food, that will stimulate gastrin release. When the pH in the stomach begins to rise, that's called alkalinization of the stomach, and that will stimulate gastrin release. When you consume foods, they begin to neutralize the acid and they raise the pH in the stomach, and that's a stimulus for gastrin release so that more acid will be secreted to keep the pH low. Certain amino acids can stimulate gastrin release. Phenylalanine and tryptophan are particularly potent stimulants of gastrin release. I've shown their structure on the screen here to remind you that these two are very important. And then finally, the vagal nerve can stimulate gastrin release, but interestingly, it uses a unique neuropeptide. It does not use acetylcholine. It uses a neuropeptide called gastrin-releasing peptide. It's an appropriate name for this peptide. And the reason this matters is because anti-muscarinic agents that block acetylcholine, like atropine, do not block gastrin stimulation of acid release, and that's because the neurotransmitter GRP is used in this one special situation. There are two inhibitors of gastrin release that you should know. One is a low pH, so when the pH starts to fall, that signals that food has left the stomach and gastrin release declines. And then finally, somatostatin suppresses gastrin release. We'll talk about somatostatin at the end of this module. There is a very rare tumor called a gastrinoma that they love to ask you about on your board so they can test your knowledge of gastrin function. And when a gastrinoma produces symptoms, it produces a characteristic syndrome called the Zollinger-Ellison syndrome, named for its discoverers. These tumors secrete gastrin, as I said, and they occur in the duodenum and the pancreas. Now, the duodenum kind of makes sense because it's close to those G cells that produce gastrin. But why does it occur in the pancreas? Well, it turns out that there are some G cells that are found in the pancreas in the fetus, and they can sometimes persist into adulthood and develop into gastrinomas. Patients who have the Zollinger-Ellison syndrome and a gastrinoma obviously have excessive acid secretion. In addition, They develop hypertrophy and hyperplasia of the stomach mucosa. Patients with the Zollinger-Ellison syndrome and a gastronoma present with abdominal pain and diarrhea. The abdominal pain occurs because of the excessive acid production. Acid is damaging to the stomach, but normally your stomach can protect itself with mucus and bicarb, but in the setting of excessive acid production, as occurs in a gastronoma, the stomach can't protect itself and it becomes inflamed. This symptom will improve with food because food will temporarily raise the pH and slightly neutralize the stomach contents, and this will provide some brief relief. Patients with a gastronoma also develop chronic diarrhea. So why does this occur? Well, all that acid overwhelms the neutralizing capacity of the intestines. Normally, when food reaches your intestines, the pH rises, but this can't occur when there's excessive acid. So acid spills into the intestines, and the low pH in the intestines inactivates the pancreatic enzymes. They don't function well at a low pH. In addition, all that acid in the intestines inhibits sodium and water absorption in the small intestine. So as a result, patients with the Zollinger-Ellison syndrome have poor digestion, steatorrhea, and they can have a secretory diarrhea from all of the sodium and water spilling into their intestines. In addition to abdominal pain and diarrhea, when these patients inevitably get an endoscopy, you will see ulcers. That's from all the acid production. And importantly, these ulcers are often in the distal duodenum, far beyond where ulcers are usually seen. If we go back to this picture of the stomach, most duodenal ulcers occur in the portion of the duodenum right here, which is closest to the stomach. This portion is called the duodenal bulb. But in patients who have the Zollinger-Ellison syndrome, there can be so much acid that it can wash far down into the duodenum, beyond the bulb, and even into the jejunum. And when endoscopists perform an endoscopy and they see ulcers in the duodenum far beyond the duodenal bulb or in the jejunum, one of the things they think about is that the patient may have a gastronoma and the Zollinger-Ellison syndrome. Another feature of the ulcers in a gastronoma are that they are refractory to proton pump inhibitor therapy. Proton pump inhibitors are the standard therapy for ulcers, and they don't work in patients who have the Zollinger-Ellison syndrome. And then finally, all that acid in the stomach can get into the esophagus, and this can cause heartburn. You can diagnose a gastronoma by measuring a fasting serum gastrin level. It's important that the patient is fasting because food stimulates gastrin release. And if a fasting serum gastrin level is greater than 10 times the upper limit of normal, that suggests a diagnosis of a gastronoma. Another important test that you should be aware of, especially for step 1, is the secretin test. Secretin is another hormone that I'll talk about later in this module, and you can use this hormone to differentiate gastronomas from other causes of high gastrin levels. Normally, the G cells are inhibited by secretin. However, gastronomas behave the opposite way. They are stimulated by secretin. So if you administer secretin to a patient and the gastrin level rises, that suggests that the patient has a gastronoma. There are several ways to treat gastrinomas. One way is to administer high dosages of proton pump inhibitors like omeprazole, lansoprazole, and pantoprazole. As I told you before, these drugs are standard therapy for ulcers, and usually patients with gastrinomas are refractory to these drugs. However, you can try very high dosages. That is sometimes effective. An alternative is to use a synthetic version of the GI hormone somatostatin called octreotide. We'll talk about somatostatin later in this module, but it is a GI hormone that shuts down release of many other GI hormones, including gastrin. And there is a synthetic version of somatostatin called octreotide that you can administer as a drug, and it will inhibit gastrin release for some patients. And then finally, you can surgically excise the tumor. Pernicious anemia is a type of anemia that occurs when patients have autoimmune gastritis. I talk about this in detail in other modules, but these patients lose their parietal cells in their stomach and they lose intrinsic factor, and therefore they cannot absorb vitamin B12. What I want to mention to you here is that high gastrin levels are a typical finding. Gastrin is intended to stimulate the parietal cells, but those cells are destroyed by the gastritis. As a result, gastrin levels rise and rise and rise, trying to stimulate the parietal cells that are being damaged by inflammation. You can also see G cell hyperplasia in pernicious anemia. Our next hormone is cholecystokinin, and cholecystokinin has two major effects that you should always remember. The first one is gallbladder contraction. I've shown a picture of the gallbladder here to remind you of that. And cholecystokinin is also important for stimulating the secretion of pancreatic enzymes. This hormone is released by cells called I cells. They're found in the small intestine, mostly in the duodenum and the jejunum. Cholecystokinin will make the gallbladder contract and release bile. It will also stimulate the pancreas to secrete enzymes. The way by which it stimulates the pancreas is indirect. There are cholecystokinin receptors on the vagus nerve, and when they get activated, the vagus nerve releases acetylcholine, which stimulates the pancreas. Cholecystokinin will also make the sphincter of Oddi relax. This should make sense to you. If bile is going to be coming down from the gallbladder and pancreatic enzymes are going to be coming toward the intestine, you want the sphincter of Oddi to relax and open so that those substances can reach the duodenum. And then finally, cholecystokinin inhibits gastric emptying, and this allows time for bile and pancreatic enzymes to work in the intestines. The major stimuli for cholecystokinin release are fatty acids and monoglycerides and amino acids and small proteins. Interestingly, we consume a lot of triglycerides in the food that we eat, and those are not stimuli for release of cholecystokinin. However, there is some lipase enzyme in your saliva, and that will begin to break the triglycerides down into fatty acids and monoglycerides, and those can stimulate pancreatic enzyme release, and one of the pancreatic enzymes is pancreatic lipase, which will break down more triglycerides into fatty acids and monoglycerides, and therefore those will stimulate more CCK release. There is one clinical scenario where we sometimes use cholecystokinin for diagnostic purposes, and that is in a HIDA scan, which is a gallbladder and liver scan. HIDA stands for hepatic aminodiacetic acid. It's a method of taking pictures of the gallbladder, which is called cholecystography. It's also a method of diagnosing right upper quadrant pain. A HIDA scan is often done when a patient has right upper quadrant pain and an ultrasound is non-diagnostic, meaning it doesn't show gallstones or some other obvious cause for the right upper quadrant pain. The way you do a HIDA scan is you administer radio-labeled HIDA to the patient, and HIDA will concentrate in the gallbladder and pass to the intestines, and you can follow the radioactivity. If the HIDA does not fill the gallbladder, this suggests there's some type of obstruction to bile concentrating in the gallbladder. Additionally, we sometimes administer cholecystokinin after we've given HIDA to the patient. You can measure the gallbladder radioactivity before and after cholecystokinin is administered, and in doing so, you can determine a gallbladder ejection fraction. And if the gallbladder ejection fraction is very low, it suggests the patient may have gallbladder insufficiency, and sometimes those patients benefit from gallbladder surgery to remove their gallbladder. Sometimes this improves their right upper quadrant pain. Our next GI hormone is secretin, and secretin's job is to raise the pH in the small intestine. It's released by S cells of the duodenum. I've shown you a picture of the duodenum here to remind you of that. And it's released in response to protons in the duodenum and also to fatty acids in the duodenum. The duodenum likes to have a relatively normal pH much higher than the pH in the stomach. So when acid and stomach contents get in here, secretin is released to raise the pH, and that is where the pancreatic enzymes can function better so that digestion can proceed. Secretin has a number of different effects, but the most important one that you always want to remember, especially for step 1, is that it increases bicarb secretion by pancreatic duct cells. I talk about how this occurs in detail in the module on exocrine pancreas function. The bicarb coming from the pancreas neutralizes acid coming from the stomach so that the pH rises in the duodenum, and this allows pancreatic enzymes to function because they don't work well at a low pH. In addition, the low pH is damaging to the small intestine. There is also evidence that secretin directly inhibits gastric acid secretion. Many mechanisms have been described, but one of the important ones that we'll talk about in a minute is that secretin normally suppresses gastrin release. This does not occur in gastrinomas, and that's one of the clinical uses of secretin. We'll talk about that in the next slide. Secretin has also been shown to increase bile production, and it also promotes pancreatic flow. Water is secreted with the bicarb that gets stimulated to be released by secretin, and then this flushes pancreatic enzymes into the intestines. So a key clinical use of secretin is in gastrinomas, which are those rare tumors I talked about a few slides ago. There is the secretin stimulation test. Normally, secretin suppresses gastrin production. However, in patients who have gastrinomas and gastrinoma cells, secretin has the opposite effect. It increases gastrin production, and that's one of the ways to diagnose a gastrinoma. Our next GI hormone is somatostatin, and I think of somatostatin as a wet blanket to the GI tract. It inhibits the release of most other GI hormones. It's synthesized and released by cells called D cells, which are found throughout the GI tract. Somatostatin is also found in nerves throughout the body, and if you remember this fact, it can help remind you that somatostatin has many effects outside of the GI tract. In fact, it was originally discovered in the hypothalamus, and it was shown to inhibit growth hormone release. Somatostatin can act as a hormone. It can be released into the blood and affect distant targets. It also often functions as a paracrine, which means it affects nearby cells from where it is released. One of the major stimuli for somatostatin release is a low pH. When the pH is low, that increases the amount of somatostatin which is released, and I've described how this aids in digestion at the bottom of the screen. When food enters the stomach, the pH in the stomach begins to climb. That shuts down somatostatin release, and therefore the other hormones can work, because remember, somatostatin is inhibitory. When its level gets low, the other hormones are able to function. When digestion is complete, acid begins to reaccumulate in the stomach. This triggers somatostatin release and shuts down the digestive process. In this way, somatostatin plays a role in regulating digestion and acid secretion. The vagus nerve can decrease somatostatin release, and that should make sense to you because as you begin to think about eating a meal, your vagus nerve becomes active and it will shut down somatostatin release so that those other hormones can begin to work. The inhibitory effects of somatostatin are many. I've summarized some of the important ones on the screen here. Somatostatin can inhibit gastric acid release. It can inhibit secretion of pepsinogen. It can also blunt gallbladder contraction. It can inhibit pancreatic fluid secretion and intestinal fluid secretion, and it can blunt insulin and glucagon release. As I said before, it's hard to remember all these, but you can just think of somatostatin as a wet blanket that shuts down the release of many gastrointestinal hormones. The most important clinical correlation of somatostatin is octreotide. This is a drug that is an analog of somatostatin. The place where you will most often see it used is in upper gastrointestinal bleeding, although it has other niche roles, which I'll talk about on the next slide. When patients have a bleeding varices is a blood vessel in their esophagus or stomach. It occurs in patients with liver disease and portal hypertension. And when these blood vessels bleed, these patients can exsanguinate and die. This is a bleeding varices as seen on an endoscopy. Octreotide is administered to these patients because it reduces splanchnic blood flow and it decreases the amount of bleeding from these bleeding varices. Ultimately, the treatment usually involves surgery or banding so that they stop bleeding, but the octreotide can definitely help. There are several other niche roles where octreotide is useful. One of these is the carcinoid syndrome. There are somatostatin receptors found on the majority of carcinoid tumors. Carcinoid tumors are usually found in the GI tract. They release serotonin and they can cause significant flushing and diarrhea. And the flushing and diarrhea will improve significantly if you administer octreotide to these patients. In acromegaly, they can inhibit growth hormone secretion. And then I mentioned this before, but patients who have gastrinomas or another rare type of GI tumor called a glucagonoma can be administered octreotide and it will inhibit the release of these hormones. And this is easy to remember if you just remember that octreotide in general shuts down hormone release. That's how it helps in many of these disorders. Our next hormone is GIP. GIP stands for glucose-dependent insulinotropic peptide. And as you can imagine, because it has the word insulin in its name, this hormone stimulates insulin release from the pancreas. It's also been shown to have effects on the stomach where it can blunt acid secretion. It's released by cells called K cells in the duodenum and the jejunum. And the stimuli for the release of GIP include glucose, fatty acids, and amino acids. And it's unique in that it's the only hormone that's released in response to all three types of foods, fats, proteins, and carbs. And the most high-yield thing to know about GIP is that because of this hormone, oral glucose is metabolized faster than IV glucose. If you administer oral glucose to a patient, that will trigger GIP release, and that will trigger insulin release, and as a result, that glucose will be metabolized quickly relative to an IV dose of glucose, which does not trigger GIP release because it doesn't go through the intestines. Our next hormone is VIP, which sounds like GIP, but it's totally different. VIP stands for vasoactive intestinal peptide. And VIP is a special type of compound called a neurocrine, which is synthesized by neurons and released in response to action potentials onto its target cells. VIP has a couple of different effects you should know about. The first one is that it can cause relaxation of smooth muscle. This is important for relaxation of the lower esophageal sphincter. And then its other effects are similar to secretin, and we mostly know about these from patients who have rare VIP secreting tumors, which I'll talk about in a minute. So VIP can raise the pH in the intestines by stimulating pancreatic bicarb secretion, just like secretin. Bicarb draws in water, just like we talked about with secretin, and this can increase fluid secretion coming from the pancreas. In addition, also similar to secretin, VIP can suppress gastric H+ secretion. And we know this because people who have VIP secreting tumors lose the acid production in their stomach. The most important thing to know about VIP as a medical student is what happens to patients who develop very rare tumors called VIPomas that secrete the VIP hormone. These are rare tumors of the islet cells in the pancreas, and patients develop a characteristic syndrome that is based on the effects of very high levels of the VIP hormone. So first of all, they develop a watery diarrhea. This is a secretory diarrhea, and this occurs because VIP promotes bicarb secretion from the pancreas, and the bicarb draws water with it. Classically, the diarrhea in VIPoma patients is described as tea-colored and odorless. It resembles the diarrhea that occurs in the infectious disease cholera, and sometimes VIPomas are described as the pancreatic cholera syndrome. These patients also develop low potassium levels. They develop hypokalemia, and that is from the high volume diarrhea. And then finally, they develop an absence of gastric acid in the stomach, which is called achlorhydria, and this is because another one of the effects of VIP is to suppress proton and acid production in the stomach. Sometimes this syndrome is called the WDHA syndrome. That stands for watery diarrhea, hypokalemia, and achlorhydria. The typical case of a VIPoma that you should know for your boards is an adult. This usually occurs in adults about 30 to 50 years old. They present with long-standing watery diarrhea. There's no blood, no pus, nothing to suggest an infectious cause. Usually they are tried with dietary changes like eliminating lactose and thinking that this might be lactose intolerance, but they have no response. If an endoscopy is done, the fluid in their stomach and intestines can be sampled and it will have a high pH. And if you do serum testing, you will find an elevated level of VIP. The treatment of VIPomas includes fluid and electrolyte replacement. These patients are often dehydrated. And then this is another niche role for octreotide, that analog to somatostatin. It will shut down VIP production by these tumors. Often these tumors are metastatic at presentation. Surgical resection is sometimes possible, but not always because of metastases. And they have a not so great prognosis. The median survival is only about 8 years. The last hormone we'll discuss is motilin. Motilin is released by cells in the stomach, the intestines, the colon. It promotes motility in the fasting state. The highest levels of motilin are found between meals. It helps keep things moving through the GI tract when you're not eating. The most important thing to know about motilin is that the antibiotic erythromycin binds motilin receptors, and for this reason you can use the drug erythromycin to treat gastroparesis. When patients have a frozen stomach or intestine, this often occurs in diabetics, you can administer erythromycin and improve motility, and that will give them less abdominal pain. On this slide, I've shown the major locations from which the different hormones we've been discussing are secreted in the GI tract. Now, different textbooks will have slight variations on the chart I've shown on this slide. That depends on which studies they are referencing, but what I've shown you here are the major locations from which these hormones come. So gastrin, for example, mostly comes from the antrum, although you can find small amounts in the small intestine. CCK, secretin, and GIP are largely duodenal and jejunal hormones. And then finally, motilin, VIP, and somatostatin can be found to some degree along the entire length of the GI tract from the antrum to the ileum. As I told you before, you may see slight variations on this graph in different textbooks, but these are the major locations for all the hormones we've been talking about in this module. I'll finish this module by talking about the 3 phases of digestion and how the different hormones we've discussed play a role. The first digestive phase is called the cephalic phase. This is when you are thinking about eating, maybe you see food or you smell food. And the major player in this phase of digestion is the vagus nerve. It can directly stimulate acid secretion. It can also stimulate gastrin release from G cells, and that can stimulate acid secretion. And all of this gets lots of acid in the stomach so that the stomach gets ready to digest food. The next phase is called the gastric phase. This happens after you consume food and the stomach has become distended. So there's gastric distension. The pH in the stomach begins to rise because it's been exposed to food, which buffers the stomach pH. There are also amino acids in the stomach, and all these things can trigger gastrin release from G cells, which can trigger more acid secretion to try and help digest these foods which are now in the stomach. And then the final phase of digestion is called the intestinal phase. In this phase, food has reached the small intestine, so fatty acids and amino acids and protons are present in the small intestine. These things will trigger the release of cholecystokinin, which will stimulate the gallbladder to contract. It will stimulate the release of pancreatic enzymes, and it will relax the sphincter of Oddi. Secretin will also be released, which can promote bicarb secretion by the pancreas. And both secretin and GIP have inhibitory effects on proton secretion in the stomach, so it will shut down stomach acid secretion because that is no longer necessary as food is moved into the intestine. And that concludes our module on GI hormones.